Hello, thank you so much for the invitation to speak at this event. I'm really thrilled to be presenting virtually. And the title of my talk is Exercise as Medicine in Genitourinary Oncology, Reducing Health Disparities in Prostate Cancer Survivors. I will also integrate discussion of other types of GU cancers as well, just to lend to examples of exercise as medicine. My name is Christina Dieli-Conwright. I'm an associate professor at the Dana-Farber Cancer Institute, Harvard Medical School. And again, thank you for the opportunity to speak today. Jump right in. The first couple of slides here are a disclaimer, if you will. They describe the paradigm at which I view exercise and is the focus of my research laboratory. So actually what we do is we use the translation of sports science to exercise as medicine, and that involves the application of training principles from sports science being applied to clinical populations. So in order to do this, we think about the parameters on the left that we draw from sports science: goal-focused performance testing, periodization or progression of training, and oversight by qualified trainers. We take all of those components and we're easily able to apply those to individuals who've been diagnosed with cancer. Our goal would be our primary outcome. We do performance or fitness testing in order to understand an individual's baseline health. We progress exercise over time, and we use integration of cancer exercise trainers. Additionally, the goal of our research lab is to optimize treatment outcomes and reduce comorbid conditions with exercise among cancer survivors in an effort to progress exercise oncology research. Here you see on this particular figure the trajectory of health outcomes over time. Traditionally speaking, we would see health decline potentially as a result of the cancer itself or the treatment toxicities. That's shown in the red dashed line. In the dashed purple line, we see that these health outcomes are further worsened in minority populations, such as Black and Hispanic populations. So we use exercise, which is displayed in the solid blue line near the top, to uplift those health outcomes in our laboratory. And we do so across the trajectory: prehabilitation, immediately post-surgery, during chemoradiation, or post-treatment. So the objective of today's talk is to demonstrate that exercise as medicine is an integral component of supportive cancer care, particularly for GU cancer survivors. I'm going to describe the problem briefly, which you all are familiar with, focus then on the solution of exercise medicine, and then wrap up with some gaps in how we need to or should be thinking about advancing standard of care with exercise integration. So briefly here, the problem that we often see is that cancer survivors are a vulnerable population prone to this phenomenon of accelerated aging. Many GU cancers are diagnosed in older adults. However, that still involves an accelerated aging process in a population that is already experiencing age. And this particular figure is a hallmark figure, if you will, that demonstrates in the dashed blue line that individuals with a cancer history are going to experience frailty, premature accelerated aging more so than those without a cancer history. In addition, in some GU cancers, this is specific to prostate cancer, there's various treatment toxicities. Here in the case with androgen deprivation therapy, or ADT, that leads to complications that naturally affect many body systems, including reductions in lean mass, increases in fat mass, reductions in physical function, and reductions in quality of life. So what is a promising solution here? Well, we know that exercise improves many health outcomes after treatment. That's where the majority of exercise oncology research lies. And this is across multiple diagnoses, not just in the GU space. We know from years and years of research now that quality of life is enhanced, individuals have less anxiety, depression, and fatigue, and they experience improved physical function and fitness. And such, we know that there are exercise recommendations for cancer survivors that have long been established by the American College of Sports Medicine as well as the American Cancer Society, and are further supported by organizations such as ASCO and NCCN. These recommendations include 3 times per week of approximately 30 minutes of aerobic exercise per session at a moderate to vigorous intensity. Resistance exercise is encouraged to be performed 2 to 3 times per week utilizing 2 to 3 sets of large muscle groups. And additionally, there's a further recommendation of reducing sedentary time whenever possible. We further know that there's generally multifaceted benefits of exercise, with the majority of work being investigated among prostate cancer survivors when we're looking at the whole landscape of GU cancers. This here is a summary of all of the improvements that have been shown to date, with less evidence to support improvements in treatment tolerance and improvements in treatment efficacy, but that research is currently underway. So you can see here this particular schematic shows a multitude of effects: reducing fatigue, improving range of motion in the joints, improving muscle conditions, bone density, reversing deconditioning, improving chance of survival. We know that from epidemiologic research, improving quality of life, reducing recurrence, improves balance, pelvic floor function, immune function, aerobic capacity, mood, and sense of control, as well as reduces chemo brain. So this really covers perhaps almost every body system. Systems that maybe aren't on here are probably just understudied, and I would probably argue we can find some literature to support that. So as you can see, there's quite a bit of evidence to show exercise is medicine, and is certainly a sort of a potent anti-cancer, anti-treatment toxicity therapy or drug, if you will. So I'm going to go into various aspects of the cancer trajectory, and I'm going to start with prehabilitation or pre-surgical, and I'm going to summarize the literature for the most part and then display some of the research that we have going on or have finished in my laboratory. So I'm going to start with pre-surgical exercise as being beneficial for cancer patients. This is a trial of approximately 18 studies, a meta-analysis from 2018 that included GU cancers such as prostate and bladder. Now, duration of prehabilitation exercise is quite variable. So in this particular analysis, there was a duration of 1 day of exercise up to 3 weeks. As you can imagine, we're trying to fit exercise into that time frame from diagnosis to surgery or to initiation of first therapy. Here, what you can see in the top figure is that pelvic floor muscle training actually improved incontinence. And we also noticed from this study that exercise reduced hospital stays and post-surgical complications, as you can see from these confidence intervals that are less than 1 down at the bottom there. In fact, this translated to 5 fewer days in the hospital and 55% reduced risk of complications. In our laboratory, we're currently conducting a pre-surgical intervention specifically for individuals who are preparing to undergo radical cystectomy that have been diagnosed with bladder cancer. This is in collaboration with a colleague of mine, Matt Mossonen, who is a GU surgeon. Prehabilitation, as we know, refers to exercise, but also other modalities such as nutrition, stress reduction, smoking cessation, etc., prior to some type of medical event. So it doesn't have to be surgery. However, we know that prehabilitation has not been consistently integrated into various disciplines in order to help, if you will, train a person up to be the most robust, strong patient they can be going into some of these debilitating procedures. So over time, Matt Mossonen and I have developed a booklet to help guide patients through prehabilitation. This is just a snapshot of it here. From the exercise standpoint, they receive various exercise under supervision virtually with an individual from my team. There is a relative focus on pelvic floor strength in this particular program, but not the sole focus, as you can see by the upper body exercises. And what's great about this particular trial is it's not just exercise, although that's the component that my team leads. There's also nutritional intervention where patients receive supplemental shakes preoperatively and postoperatively as well. And I mentioned they receive exercise in the prehabilitation setting. It's more resistance exercise involving light bands. They are encouraged to do aerobic exercise on their own. Sessions are relatively short, less than an hour, and this is conducted over Zoom, and we send all of the equipment to the patients that they might actually need. So this trial's underway. We've enrolled 30 patients to date with 90% adherence to exercise. We're really excited to wrap up this pilot trial, and we'll actually be applying for larger grants in the early winter. So exercise during therapy, this is an area that is also a little bit tricky to intervene in, but has similarly been found to be beneficial. This here is just literature showing that exercise improves muscle strength and lean body mass, which are really critical to maintain as individuals undergo chemotherapy, radiation, etc. This is noted from a meta-analysis of 13 studies that did include prostate cancer. Over 1,100 patients and 43% were male. Median intervention was 15 weeks, which is a solid amount of time to show these types of positive changes. And just to summarize some key points, there was an average gain in strength of 26 kilograms and an average increase in lean body mass by 0.8 kilograms, which may not seem substantial, but it's actually quite a bit given that these individuals are undergoing therapy and it's very difficult to increase lean mass even without concurrent therapy going on as well. So this is really promising results. We've done a number of studies during therapy in our group. This one here I'll just highlight because it does involve the GU cancer survivorship population, where we're looking specifically in minorities, Black and Hispanic patients who are receiving chemotherapy for their cancers. And ultimately we're trying to use this preliminary pilot study to determine if individuals prefer supervised or unsupervised exercise while they're undergoing chemotherapy. And we're using this data to prepare for a phase 2 randomized controlled trial focused on heart disease and reducing comorbid conditions during chemotherapy, which tend to become exacerbated with therapies and more so in the Hispanic and Black cancer populations. So really excited to wrap this trial up, which will be ending by the end of the year. So I'm going to shift a little bit through to, post-cytotoxic therapies, if you will, and share some studies that we've done more recently in prostate cancer. We had the opportunity to study resistance exercise strictly, actually in a periodized fashion, meaning that we systematically program the resistance exercise week by week based off of individual strength testing. And we were trying to target lean mass, given the substantial decrease in lean mass over time on this population on ADT. If you look at the left, there's a table there that shows sarcopenia prevalence. And in the exercise group, about 40% of the individuals had sarcopenia when measured off of a whole body DEXA scan. The no exercise or control group, almost half had sarcopenia. And after 12 weeks of resistance exercise, that number went from almost 40% to 15% who had sarcopenia. So we did find, as you can imagine, and shown in the next two figures to the right, significant increase in lean mass over the course of the 12 weeks. Now, what's important to note in this study is there was, I believe, 99% adherence. This was in-person exercise. This was actually done pre-COVID, and the individuals were lifting very, very heavy weights, which is in many cases necessary to actually cause hypertrophy in muscle. Also with this study, we found improvements in quality of life, which is shown on the left there. We saw trends, but no significance in changes in fatigue and depression. So we further wanted to look at additional modalities of exercise in prostate cancer survivors. This here study is our circuit training study that also involves breast and colorectal cancer survivors, but I will focus on the prostate cancer population for the sake of this talk, where we were utilizing both aerobic and resistance exercise, but performed in a circuit fashion. So that's what you see in the diagram on the right. So the individual would walk, jog, or run on a treadmill. Then the only rest that they would receive is having the transition time from one machine to the next. So there was no formal rest period. They would go through the entire circle or cycle of exercises. Then they would get 1 minute rest before they get back on the treadmill. We did this type of training because there's evidence in the exercise science and sports science literature that this type of training is actually superior when we're trying to improve fitness, cardiovascular disease risk, and body composition. So this was a pilot study we did. Here is the data that we looked at specifically related to heart disease and vascular function. And here we showed that this type of exercise can improve endothelial dysfunction, which again is a measure of vascular function, which is highly related to different heart disease measures. This was done by ultrasound, where we looked at brachial artery flow-mediated dilation, and we saw significant improvements in that flow-mediated dilation in the exercise group shown in the blue bar. We further looked a little bit deeper at endothelial dysfunction by measuring carotid intima media thickness. And in this case, you actually want that measure to decline so that the vessel is less thick. And we saw that actually happen significantly in the exercise group. We further looked at fitness, and we saw their fitness improve by an average of change in VO2 peak of 5.12 mLs per kg per minute. And unfortunately, this same measure actually decreased in the control group. So in other words, even though these individuals were off cytotoxic therapies, they still experienced declines in fitness, while the exercise did the opposite and showed those improvements. So sort of continuing to progress, does exercise improve mortality among cancer survivors? This question is actually asked quite a bit and is a tough one to answer. The bulk of literature that shows a positive result thus far in epidemiologic research is among breast and colorectal cancer survivors. However, I will talk about the challenge study, which I know was presented at ASCO a few months back as well. I'll get to that towards the end. But I did want to actually share something promising that does apply quite heavily to GU cancer survivors, and that's resistance exercise. Given the dramatic decrease in lean mass and increase in the prevalence of sarcopenia, I think this modality of exercise is often preferred. So this is just a study of almost 3,000 patients, 18 to 81 years of age, who self-reported yes or no to whether or not they participate in resistance exercise. And here you can see on the graph on the right that those who did participate in resistance exercise was significantly associated with a 33% lower risk of all-cause mortality. Resistance exercise is actually rarely measured stringently in epidemiologic cohort studies. We're actually validating a questionnaire for that in our lab as I speak, and hopefully those results will come out next year so that we can have better integration and better capturing of self-report resistance exercise and many epidemiologic studies across the globe, hopefully. So I wanted to wrap up this particular section on what are we doing now additionally to continue to study GU cancers. We have a trial that's wrapping up that's a pilot study funded by Prostate Cancer Foundation and DoD looking at exercise to enhance cardiovascular health among Black men with prostate cancer on ADT. This is our POWER trial. This is quite a large pilot trial actually. We're almost getting to a total sample of 62 patients. And we've actually just been submitting this project to various sponsors in hopes that we can continue on with this work. It's supervised, it's virtually supervised, The equipment is also sent to the participants' homes, and we're looking at cardiovascular risk by calculating the Framingham Risk Score, as well as fitness outcomes, quality of life, and then we do a 12-month follow-up to track any cardiovascular events. But we've analyzed some preliminary data, and we have found that this type of exercise, again, aerobic and resistance exercise, significantly improves cardiorespiratory fitness, as you can see by the change in the blue bars on the graph on the left. And you can also see that Framingham Risk Score also improved in the exercise group. So this gives us some preliminary evidence that specifically in this group of high-risk men, Black men with prostate cancer, who are largely understudied and in GU cancers, can exhibit these benefits of exercise. We have an ongoing trial referred to as the FIERCE trial, also funded by PCF, that's looking at debunking the frailty, sarcopenia, ADT axis, and metastatic prostate cancer. This trial actually has only been going on for a short period of time, so we don't have preliminary data available just yet. But what's unique about this trial is that we are actually obtaining muscle tissue by doing muscle biopsies of one of the quadricep muscles, the vastus lateralis. So we'll not only be able to target frailty, with resistance exercise, but we're also looking at direct measures of sarcopenia by looking at catabolic and anabolic measurements in the muscle tissue. We're also looking at body composition. And we'll do some analyses to look at biochemical progression of disease. This is a multi-component exercise program, so we really thoughtfully derived this program around inclusion of resistance training, functional exercises, including balance. They are encouraged to do self-directed aerobic exercise, and the exercises are performed in a circuit fashion. So on that note, I just wanted to move forward just a little bit in thinking about where do we go from here with exercise medicine, exercise oncology as it pertains to GU cancers. Clearly, the bulk of work has been conducted in prostate cancer. We're trying to do more work in bladder cancers, but there are obviously many other GU cancers that are largely understudied. But I'd be remiss to not mention the challenge study, which, as I alluded to earlier, was presented at ASCO and caught quite the press. So this is one of the first studies to demonstrate that structured exercise actually improved mortality outcomes, and they found that structured exercise had a very similar potent effect of anti-cancer as some chemotherapy drugs. While this is in colon cancer, there are other trials ongoing similar to this theme that are out there in GU cancer, specifically in prostate cancer. The GAP Interval 4 trial, and some others, to name a few, that are trying to do something similar, although different, if you will, but in the prostate cancer space. So stay tuned for that. Those trials will likely be out within the next couple of years. For those of you familiar with the details of the challenge trial, it took quite a while, over 15 years, to actually conduct this study. So as you can imagine, these trials that are intervening rather than observing with epidemiologic work can take quite a bit of time to actually deliver the intervention after recruitment and then follow up long enough to be able to calculate some type of mortality or disease risk. So where do we go from here? Specifically, I wanted to tie in, where our lab is going. And we actually have a new trial that was funded by PCORI that is a phase 3 trial. And we decided to focus here on older adult cancer survivors plus their support person. So for the standpoint of our grant, it's a support person that is somebody they reside with, so that we could truly tap into a dyadic intervention where they're doing everything together. And we're intervening with a Mediterranean diet and an exercise program. And there's actually two groups, supervised versus unsupervised. So it's a non-inferiority trial. There's no control group. Everybody gets something. And we're primarily focusing on cognitive function and physical function. And this will be in a total of 764 dyads across both the Dana-Farber and University of Miami. We actually just opened for enrollment a couple of weeks ago. And so hopefully within probably the next 4 to 5 years, we'll have some interesting data to show here. But what we really want to demonstrate here is not just the benefits of exercise on these outcomes, which we suspect will change, but we want to establish, do we need that supervision or not? If we find that supervision is really critical in improving our outcomes, that's where we want to focus our efforts on standard of care and policy change. And so far, all the data does seem to point in that direction. But if we don't need that supervision, preliminary data, I should say, prior to this trial, but if we don't need that supervision, then we can forego that and we can start to think about other practical ways we can disseminate exercise without that supervision. So just to wrap up here, we truly feel that exercise is a source of medicine and is necessary to help to transform cancer care, specifically supportive care and various health outcomes. We can really derive quite a bit of knowledge, and already have, from existing programs such as cardiac rehab, diabetes prevention, and really combine that with exercise oncology research to demonstrate that exercise oncology is necessary as a supportive care modality, in the hopes that one day we will have insured exercise programs for all cancer survivors. And the impact of this is really quite simple. 31% of the world's adult population is physically inactive. That's over 1.8 billion people. As experts in GU cancers, you can extrapolate what that would be specifically with GU. But we know the economic burden of physical inactivity is over $300 billion by the year 2030. So this truly is a way that we can not only have a positive impact on individuals' lives by encouraging them to exercise, experiencing the benefits of exercise, but also this is cost reductive as well. And on that note, I would like to thank you so much for your time and the opportunity to present to this group. And I would absolutely be happy to take any questions. And I also have contact information on this slide as well. And I would be happy to connect over email. Thank you so much to my team who conducts this research alongside with me, our sponsors, and also to the participants. Thanks so much.